Yes, welcome. Hello, everybody, and welcome to our webinar. My name is Konstantinos Antypas, and I'm the chair of the Telenursing Working Group of the International Society for Telemedicine and Health. That is also the organizer of this webinar. Before we start, I would like to say a few words for the International Society for Telemedicine and Health. This is a very short introduction, and also present our working group, the working group for the telenursing. I hope now that you can see my presentation and you can also hear me. The International Society for Telemedicine and Health has as a mission to facilitate the international dissemination of knowledge and experience in telemedicine and e-health, and is providing access to recognized experts in the field worldwide. It has a long history that goes back to 1993, but also a very important presence today. Here you can see the current board of directors, along with the co-opted members and also the management board. As you can see in this slide, there are several countries represented in the International Society for Telemedicine and Health, 103 countries and territories. And the society exists to facilitate the international dissemination of knowledge and experience in telemedicine and health, and to provide access to recognized experts in the field worldwide, as I also mentioned before. It's a non-governmental and non-for-profit society that has close ties with the World Health Organization. It's primarily an umbrella for national telemedicine and e-health organizations, but also including associate, institutional, corporate, individual, and nurse and student members. And it supports the studies in policies, regulation and standards, business model and reimbursement, education and training. It's assisting to the startup of new national organizations. It's a very important actor in networking and as a scientific platform, and is organizing annual international events. In the International Society for Telemedicine and Health, there are several working groups to represent the different interests of the members. One of them is, of course, our working group, the Telenursing working group, but there are also others like students, for women, education, telecardiology, and also you can see all the working groups here. And of course, if you're interested, you can go to the website of the International Society for Telemedicine and Health, become a member, but also join one of the working groups. Now going to our working group, I would just want to present it. I am the chair of the working group, and I also have the honor to have as co-chairs Pirkko Kouri, that is also a vice-president of the International Society for Telemedicine and Health, and our previous chair, Claudia Bartz. Our group has about 160 members, nurses from all over the world, and our vision is to enable nurses to extend their reach through technology while improving the quality of the healthcare delivered worldwide. And our mission is to provide a forum for exchange of knowledge and experiences of nurses and others who are working with or supporting nurses using e-health applications. The last year, we have several activities. We had another webinar. We also had a special theme on nurses and midwives in e-health that was published recently on the Journal of the International Society for Telemedicine and Health. And that was a special theme, a series of articles from members, and an editorial also on celebrating the International Year for Nurses and Midwives. That was 2020. We also have a Facebook page that would encourage you to like, and we are planning to use it more actively for communicating relevant news. And also, I want to present a monograph that members from our group but also other working group of the International Society for Telemedicine and Health are preparing and editing, and is a retrospective on 2020, the year of the nurse and midwife in the time of COVID-19. And I hope that we will also have the opportunity to discuss this maybe through a webinar. So if you are a nurse and you are a member of our working group, I would like to encourage you to connect with other members of the society, other members of our working group, but also other members of the society. And we are here to promote your work and to inform you about recent developments in our field. And also, if you are a nurse and you are not a member, you can apply for membership, and membership is for free, both for the International Society for Telemedicine and Health, but also for our Tele-Nursing working group. And again, it's very important that we are here for you, and we have a network. And please use this network, and we can help you to do this. So now to go to the subject today, the topic today, that is telenursing in the time of COVID-19. We have the honor to have Sharon Golini working at the University of Utah Hospitals and Clinics at Utah in the USA, and also Matthias Georgsson working at the Jönköping University in Sweden, presenting a very important and relevant. I've been now it's almost a year since, at least in Norway, we have been living in a very different way because of COVID-19. And of course, nurses professionally has been also in the spotlight during this pandemic. I've been, our working group has been doing other activities, but also has been a bit late in presenting topics relevant to COVID-19. And I think one of the reasons was the hope that this was something that would pass relatively fast, from my side at least. But we are here, and still it's a year since it all started, and we still are in the same process. So I think now we can use the experiences that nurses around the world have had to improve telenursing in health. So I would like to ask Sharon Golini to also present herself and also present her presentation, that is the topic Virtual Outpatient Heart Failure Care, Lessons from the COVID-19 Era. Sharon?
Good afternoon. My name is Sharon Ugolini Moss. I am a registered nurse working as the heart transplant coordinator at the University of Utah. I'm honored to be here this afternoon to present today regarding our experience through the first surge of the COVID-19 era with virtual outpatient visits. I'm going to share with you some of our lessons that we have learned along the way. I have no disclosures. The University of Utah Health is in Salt Lake City, Utah, in the United States, and it serves the people of Utah and beyond by continually improving individual and community health and quality of life. This is achieved through excellence in patient care, education, and research. Each vital to our mission, and each makes to the other stronger. So for the last 10 years in a row, we have been ranked among the nation's top 10 academic medical centers in quality, safety, and accountability. For 5 years in a row, we have been ranked in the nation's top 5 for ambulatory care. And in 2019, for the 6th consecutive year, the University of Utah was ranked #1 in Utah in the Salt Lake City metro area by U.S. News and World Report. In 2019, Forbes also recognized the University of Utah as one of America's best employers for the 2nd year running. We are the only Utah healthcare system included in the 2019 ranking and one of only 2 Utah employers to be recognized. The University of Utah Advanced Heart Failure Recovery Program uniqueness is attributed to the expansive healthcare service area for reaching across the Western United States. Over 70% of patients in our clinic travel to Utah to be treated. With COVID-19 travel restrictions in place, this limited the majority of our patients to access to advanced heart care. There are over 170 advanced heart failure programs throughout the United States, what makes the University of Utah unique to the incredible service area and reach we have across the Western United States. Our institution as a whole has 4 hospitals, 12 community clinics, 18 regional partners, and 1.7 million patient visits per year. Our advanced heart failure program serves not only patients from the Intermountain West area, but stretches out into the 27 states with 10 actively referring. This each extra long reach is partially due to being one of the 5 contracted with the Veteran Hospital Centers. The University of Utah Health has a long history of sharing knowledge and resources to provide quality care across the Mountain West. The affiliate network allows patients and their families to access clinical expertise, research, and resources from top-ranked academic medical centers without leaving their community, unless absolutely necessary. Since launching in 2013, the University of Utah Affiliate Network has grown to include 23 official affiliate partners and over 70 healthcare systems. And our program, as you can see, we have the experience of over 1,500 transplants, over 36 years transplant experience, and we have over 200 patients that are ongoing. We have a robust MCS program as well that's about 28 years old, and we have about 100 patients ongoing. And we do about 40 durable VADs annually and about 100 temporary. And we have 8 cardiologists, 3 surgeons, and 11 nurses that help manage our patient population. Our study begins in 2020 as it ushered in with a variety of uncertainties, including a new infectious disease, COVID-19, which quickly this became a pandemic that disrupted the traditional way healthcare is provided to patients with chronic conditions, such as heart failure. Healthcare providers rapidly explored and implemented new methods of healthcare delivery by quickly transitioning outpatient in-person encounters to be conducted virtually via telehealth. The objective of the study is to determine the impact of rapid change in healthcare delivery for heart failure patients. Specifically, whether or not virtual visits for heart failure patients altered the medical therapy needed to manage their chronic disease, and if the healthcare system's ability to adapt was hindered. Starting on March 15th, the COVID-19 pandemic had reached Utah, and non-time sensitive or urgent outpatient in-person appointments were canceled and swiftly transitioned to virtual appointments where possible. In our study, we included all appointments for heart failure in our tertiary care heart failure clinic from February 18th to March 13th to analyze patient visits in the pre-COVID era, and then from March 16th to May 15th to analyze the post-COVID era. We examined the volume of in-person and virtual visits and compared medication titration rates pre and post-COVID. We examined the data using standard statistical analysis. The study cohort included 745 patients with a mean age of 61, plus or minus 15 years. 35% were female, 81% Caucasian, and 8% Hispanic Latinos. Of these, 227 patients were seen pre-COVID and 518 post-COVID. Here you can see in the y-axis, we have a number of patients, while on the x-axis, we have a breakdown in time in weeks. The blue annotates in-person clinic visits, while in orange represents the virtual clinic visits. As illustrated in the figure, our clinic appointments were all in person pre-COVID. However, once we transitioned into a post-COVID era, Telehealth was introduced and 82% of our appointments were converted to virtual and only 18% of the appointments were in person. The star indicates weekly visit volumes in the post-COVID era that are significantly different from the average weekly visit volume in the pre-COVID era. Of note, our clinic was running close to capacity pre-COVID. As you can see, the overall outpatient visit volume decreased significantly in the first 2 weeks following March 15th. Thanks to the rapid increase, the weekly visit volumes quickly returned to normal. And in fact, in some weeks, the visit volume exceeded the average volume in the pre-COVID era. Next, we examined the rate of titration of medication. The table shows data from all heart failure patients, then separately from patients with HFrEF. In the pre-COVID era, diuretic titration took place in 33 of 227 patient visits, or 14.5%. However, titration of diuretics took place in a similar proportion of visit post-COVID, in 83 of 518 visits, or 16%. For the subgroup of patients with HFrEF, we found similar results of diuretic titration. Titration of guideline-directed medical therapy took place in 86 of 172 patient visits, or 50%, pre-COVID, and in 159 of 395 patients, or 40% post-COVID. The difference that is statistically significant. The rate of titration of diuretics or guideline-directed medical therapy took place in 59% of the patient visits pre-COVID and 49% post-COVID, also a statistically significant difference. In conclusion, we show that we were able to rapidly adapt and use the virtual visits for heart failure patients. Virtual visits improved access to heart failure clinic thanks to higher throughput capacity compared to limited physical clinic space. Guideline-directed medical therapy titration rate with virtual visit was high, 40%, but lagged behind in-person visits of 50%. Barriers to titration with virtual visits are lack of laboratory data, vital signs, and physical exam. Our future directions. We would like to identify barriers and facilitators that would allow optimizing delivery of virtual care in heart failure patients. One such approach is that we already expanded patient education to use the electronic healthcare record to upload data such as blood pressure, heart rate, weight loss logs, heart rate, as well as laboratory results obtained outside of our healthcare system. In addition, we are starting qualitative study of patients and provider experience with virtual care. We will conduct a semi-structured interviews that will allow us to further streamline virtual care in our program, improve quality metrics of heart failure care, and optimize patient experience with virtual care. The success of the adaptation of telehealth at the University of Utah in a time of uncertainty goes to providers and advanced practice clinicians and all the heart failure program staff. Without their resilience and swift adaptation, it would not have been possible to continue to provide our patients with guideline-driven exemplary care. Additionally, much gratitude to my mentors and collaborators. Thank you.
Thank you, Sharon. I think it's better to have or maybe we can have any questions if you have right now. And see now, question from Mark van der Werf. What were the top 3 challenges to implementing telemedicine in the program of the University of Utah?
I'm sorry, can you repeat that for me?
Yes. What were the top 3 challenges to implementing telemedicine in this program?
Great question. So I think some of the challenges first off was finding the appropriate platform. When this wasn't common for us to practice, we had multiple things to choose from. So at first, I think identifying the best platform and then to move forward. And over time, we were able to identify what worked best for us.
Mm-hmm.
Second, I would say physical exam. That's something that's hard to remove. So in implementing telemedicine, it's hard to, with at least heart failure patients, it's hard to assess fluid overload, JVD just through a screen. So I would say that was another challenge. And then the final challenge is user error by both patient and provider. This was a new platform, again, that everyone had to get used to. Some generations are used to using computers more than others, and so that presented a challenge as well.
Yes, thank you for the question. Are there other questions? How emergency care cases how emergency care cases were addressed in telemedicine? That's a question by Asuk Ravuri.
So the nurses would triage patients to determine whether the risk of bringing a patient early on into clinic outweighed the risk of them being at home. So the nurses would triage the patients. If a patient was either increased risk for any type of heart failure that would require hospitalization, we would direct them to the hospital emergency room. In other cases, we would bring them into clinic. And then if we did not find that they were severe to be seen in person, then we would see them on telemedicine.
Yes, while we can use a bit more time for questions. How did you solve the challenges to find platform, physical exam, and user error? This is another question.
So trial and error with the platforms. So initially, I think that's where we learned which ones by trying different ones, and ultimately the institution chose one that they like. We use MyChart. We also use Zoom, which is then protected for PHI through our system. For physical exam, we would walk our patients through to determine like how to do a physical exam. If we found that to be limiting, then again, we would change the visit to an in-person visit and bring the patient in. And then again, with user error, if the call didn't work out, we would transition to a telephone encounter. And also we would have a assistant call the patient ahead of time to triage or to work out any issues with the patient prior to the provider coming onto the screen.
We have two more questions. I hope it's okay to continue. What type training did the nurses and the doctors receive prior to implementing televisits? And such as how to connect with patients, effective teaching strategies in this type of visit versus in person?
So good question. I think it was a baptism by fire at first. We were not really given a lot of options, and we had to just jump in. Our team was very amenable to that. They were quick learners and were eager to do what we needed to help our patients. And then over time, the institution provided online classes where you could participate and learn how to navigate the different platforms. And then for teaching strategies, we've actually found that it's very helpful to be able to teach patients at home where they felt more at ease and they could engage with questions. I found personally that they were less intimidated than in a clinic setting. And it also helped us to be able to provide literature ahead of time for them to be able to read and review and ask engaging questions.
Thank you. That was a question by Donna Floyd that has also two more questions. Let's try to see the next question and we see if we have time for the third one. How much, if any, telemonitoring equipment was provided to patients? And further, if telemonitoring was implemented, how did training occur?
That is something that we're still ongoing looking into providing patients that with equipment. So that is not something that we have now. I know that across the United States, we're looking a lot of institutions are looking for grants and things like that to help support providing patients with equipment for telemonitoring.
Can I ask a question here? Is it infrastructure a problem? Is access to internet and access to devices a problem for the target population of your clinic?
Actually, we found that some of them have easier access to it. Most people have a mobile. So they were able to access that. And with being rural as well, like commuting in, some of our patients travel 6 to 8 to 12 hours to come to see us. So for them to be able to stay at home has actually been very helpful for them because they didn't have to have the associated cost of travel and lodging to come to see us. And even patients locally who had issues with transportations were able to make their appointments on time and participate more. So I think that's where we saw an influx as well, in more patients to be seen in clinic because we had less no-show ratio.
Thank you. I think now it's time to go to the next presentation, but we will keep your question, Donna, and we will discuss it at the end of the other presentation too. Thank you, Sharon.
Thank
Matthias?
you.
Thank you very much. Well, I have 25 minutes presentation. I tried to speed up the pace here so we have some minutes for Q&A in the late part of this session. So we had a sound check during our test session before. I probably have some problem with my internet connection from my end. So I was told to yes, at the moment put out my video, and then I will put it on again during the Q&A session. I hope you will not disappoint if you cannot see my nice face during the presentation. So yes, when you're ready, Konstantinos. So hello, and thank you for the opportunity to present here today. My name is Matthias Hjortsson, and I'm working at the School of Health and Welfare at University of Jönköping here in Sweden, where I teach on a nursing program for bachelor and master level students in nursing informatics. And my own research focus is on chronic disease self-management, so to say, and especially mobile health solutions for patients, particularly diabetes patients so far. And I'm going to talk about Tele-Nursing in Sweden and the impact of COVID-19 in a broad sense. And I'm starting off this presentation with a short background on Sweden and its healthcare system, so just to border the area, so to say. Next slide, please. So Sweden is officially called the Kingdom of Sweden, and it's a country located in the northern part of Europe. Its capital is Stockholm, and it's bordered by Norway to the west and north, and Finland to the east, and is connected to Denmark in the southwest, actually by a bridge and tunnel across the Öresund Strait. And also Sweden has about 450,000 square kilometers, the size of Sweden, and Sweden is the largest country in the northern Europe, and the third largest country in the European Union, and the fifth largest country in Europe in terms of size. So we have lots of telemedicine opportunities in this country, so to say. Next slide, please. So population density. Sweden has a total population of roughly 10.4 million and a low population density of just 25 inhabitants per square kilometers. And 87% of Swedes live in an urban areas, and that's mainly Gothenburg city, where I live on the west coast, is Malmö city on the southern part towards Denmark, and it's Stockholm city in the middle part of the upper middle part of the east coast of Sweden towards Finland. And the highest concentration inhabitants is in the central or southern part of the half country. Next slide, please. So Demography. The average life expectancy are about 84.7 years for females and 81.3 for females. For males, probably. Sorry. And the figures inside the brackets are before the COVID-19 hit this country. So it actually, you can see that it declined during this year. And the life expectancy has increased considerably, and therefore, well, on the long run, if we count out this last year, unfortunate year, and therefore also the amount of elderly in the population has raised. So today, every fifth inhabitant in Sweden is now 65 years of age or older, and this varies, however, between different counties. There are some municipalities where over 30% of the inhabitants are more than 75 years of age, and these are often in small communities that during a long time have had a large share of people at working age leaving to work in the cities. So the old people stay and the younger generation leave to work opportunities in the cities. So from the year 2020, it's expected that the number of inhabitants over 80 years of age will continue to increase. And according to the Swedish statistic authorities, based on a prognosis from April 2019, the number of inhabitants over 80 years of age will increase with more than 50% between 2019 and 2030. This is equivalent of an increase by more than 270,000 persons, on which 130 will be over 85 years of old. So next slide, please. Thank you. I can see it now. And this graph is based on figures from the Swedish Association of Local Authorities and Regions, and it shows the percentage of increase of inhabitants working age and the demographic demands on the solutions that are considered. So it's you can see on the middle part of the side where the red line is drawn. There are less people that have to support a huge population, especially old people, the baby boomers. Next slide, please. In this graph, you can see healthcare costs by the age peaking 88 to 100 years old. So of course, if you grow older and you maintain some chronic disease in a specific age, you probably will not, well, you probably will have them for the rest of your life, well, some of them at least. So the cost elevates and continues if you grow older. And this is a dilemma because we have this expectancy that people will become older in the future. Next slide, please. So coordination of healthcare welfare in Sweden, we have 3 main levels in coordination of healthcare and welfare. We have a national level and a regional level and the local authority level. And so on the national level, we have the parliament and the government, and they set the policies, legislation, supervision, and financial control measures. But then we had 21 regional councils, and they actually provide the healthcare and medical care in Sweden. We have some private initiatives, but they're not so common right now, but probably will become more common in the future. And then we have the local authorities, and they mainly stands for the social services, housing, and the home-based elderly care. Next slide, please. So healthcare and medical care. So it's healthcare in Sweden is mainly tax funded. It's universal for all citizens and decentralized. Although private healthcare also exists, of course. The healthcare system in Sweden is financed primarily through taxes, as I said, and by county councils and municipalities. A total of 21 countries are in charge of the primary and hospital care within the country. Private healthcare is a rarity in Sweden, and even those private institutions work on the mandated city councils. So the city councils regulates the rules and the establishment of potential private practices. Although in most countries, care for elderly or those who need psychiatric help is conducted privately, in Sweden, this is not common at all, actually. But there is some kind of change ahead of us. So, and the healthcare expenditure is around 11% of the GDP. And in Sweden, actually, by statistics yesterday, we have 127,367 certified employed nurses that actually work. We have more certified nurses, but not all of them actually work. So it's about 82 inhabitants per certified actually working nurse in Sweden. And we have around 77 hospitals. Next slide, please. And here is just a simple slide from the OECD, and you can see on the left-hand side that Sweden has 11 percentage of our GDP for healthcare expenditures, and so we are on the top side of spending money on healthcare in the OECD. Next slide, please. And next slide, please, again. So moving over to the COVID-19 situation in Sweden, inpatient care, confirmed cases, deaths, etc. In this slide, you can see the following. The x-axis shows the time from the beginning of March 2020 to the beginning of March this year. So the x-axis shows the number of individuals. The black line represents the number of patients receiving inpatient care at our hospitals, and the dark gray line, maybe it's hard to see, represent the number of patients receiving intensive care at our hospitals. So, and also on the yellow line, that is even maybe harder to see, but the yellow line represent a decrease in the number of deaths. And as you can see from this graph, this figure, you can see it's very, very obvious that first we have the first wave last winter, spring, and then we move into the summer period, and we have a little ease there, and we could catch our breath a little bit. Of course, the virus didn't spread so easy, and we were mostly outdoors, and then the Swedish autumn hit us, and then we went indoors again, and of course there was a rise in the spread of the virus in the population. So, and on the far right-hand side, you can also see that there's the figures, the graph, the lines are moving upwards again, and we are currently experiencing a third wave in most larger cities in Sweden and regions right now. So next slide, please. So I just wanted to add that the accumulated number of confirmed cases in Sweden as of the 3rd of March, I downloaded some figures, is 684,961 altogether confirmed cases in Sweden. And accumulated number of patients receiving intensive care is actually 5,332 patients. You could also bear in mind this is a nation that is around 10 million people. And the accumulated number of deaths is 13,003 people altogether. So next slide, please. Sorry, Kostas, go back to the other one. I just wanted to say some here. On the x-axis, you can see it shows time from the beginning of April to 2020 to the beginning of March. And on the x-axis, you can see the number of patients receiving inpatient care at our hospitals. So you can see here that we have a huge number of patients receiving care in our inpatient clinics, and some receiving intensive care, of course. But you can also see that this graph is following the pattern of the spread in the society quite well, the previous graph I showed on the previous slide. So, but we managed so far that around 81 to 85% were actually discharged alive from the intensive care units. Next slide, please. So in terms of COVID-19 vaccination, right now this is figures from the, I think the 5th of March, and from the Public Health Agency here in Sweden. And so we have 890,291 doses that are administered so far. And people that are fully vaccinated are around 292,867, and this amounts to 2.88% of population that are fully vaccinated. And well, the pace of vaccinating the inhabitants of Sweden, it's been delayed due to vaccine shortage. It has been it's due to delays in the logistics and transport from the supplier mainly. We have the organization in place, but we are waiting for the vaccine actually. Next slide, please, Kostas. So what about new wave or waves approaching? I think the SARS CoV-2 virus seems to continue to mutate. Well, we get some research from that, and the question is if the vaccine will continue to be effective against the new mutated variants now and in the future. And in Sweden, we now have a large spread of virus mutations, such as the British one, the Brazilian one, and the South African variants. So the answer maybe could be, the importance is that the importance of endurance and perseverance has never been greater. I mean, we are all getting tired with this situation, and the healthcare professionals are really tired and need a break. But we have to be. It's important with endurance and perseverance, and it has never been greater. And I believe that technology can help us to prevent the virus from spreading, by example, reducing the risk of cross-contamination. Next slide, please. So telenursing and telehealth in a broad sense. This website contains, this is a healthcare guide, a portal for all the citizens in Sweden. And this website contains thousands of quality assured articles of symptoms, diseases, treatments, pharmaceuticals, rules, and regulations for all the citizens in Sweden, and then can log in there from a phone or whatever device that's connected to the internet. It also provides content information to 7,000 care providers in the whole country, and it also provides symptom guidance and allows for ability to compare healthcare and dental care. There were 20 million visits in Sweden during November 2020 to this guide, this portal, and 78% occurred by mobile phones. Next slide, please. So some numbers about this portal. There's never been so many that have visited 1177. That's the trademark for this portal. And during the COVID-19 pandemic. Only in August of this year, around 50 million people visited the website, which can be compared with around 11 million at the same period the year before. So after the peak during the last spring, the interest continues, and people wanted to primarily find information about COVID-19, and also how to set up time for testing for COVID-19 and read the results and so on and so forth. So some of the most visited part of this site during the month of August were COVID-19 coronavirus and everything about test for COVID-19 and leave test for COVID-19, how they were supposed to leave it and how outdoors, for instance, outside the hospitals from the car. In March, this site had almost 90 million visits. Never before has so many visits been performed during 1 month. So it was 90 million that month. Next slide, please. So the 1177 Vårdguiden service is an e-service that allows the person to read her or his own EHR on the phone or on every device that's hooked up to the internet, and renew prescriptions and book care appointments and COVID-19 tests. Next slide, please. So some numbers. In September 2020, more than 9 million logins were made for the e-services in 1177 Vårdguiden. And this is increased by 98% compared with the same month the year before. And I should also say that we have there is a nurse triage module in this 1177. It's actually the number for the triage number, and we have a huge staff of triage nurses receiving all the calls there. And of course, the pressure on them have been tremendously increased during the COVID-19 situation. And the 21 regions in Sweden came up with a self-estimation form, digital one, that actually they had to pass before they got to a physical a nurse in the triage section of the 1177. So when that was implemented, this was actually given the nursing staff at this triage section a breather, so they can work. But still, it's a huge number of people using this telephone service and passing through the first line of support and reaching the nurse, the triage nurse. So on this slide, you can see that in September 2020, more than 9 million logins were made for these services in 1177 Vårdguiden, and this has increased, like I said, 98% compared to the same month last year. So next slide, please. So the EHR online, all the population in Sweden have access to a common EHR online, and that's also the private companies that the private providers are also connected to this service. So with the EHR online, the citizen can take part of their own information from the healthcare services, such as diagnosis, vaccines, growth curves, notes, healthcare contacts with pediatric care, test results, and aspects related to maternal care and prescription, and also referral statuses, dental care, and so on and so forth. So this is a hub in a way. Next slide, please. So some numbers about EHR online. It's used by more than 4.5 million persons in this country, and each month more than 1 million log on to the e-service system for this particular part of the suite 1177. Next slide, please. So So one feature that has been included and implemented during the COVID-19 situation is the own test results section, and there is a service for booking of tests and get the access to the test results. And the test results is actually put into the EHR online afterwards. Right now, there are about 16 regions that uses services for their own test results, handling which 3 regions uses it for COVID-19 tests alone. And this is increased 1,300% between May and June last year. So 17,373 orders were done in May and 234,269 orders in June by this system. The other paths to these test results bookings are still open, but most of the people turn to this service instead, and that was the purpose of it. So next slide, please. This is also a national platform for support and treatment programs and various kinds, such as treatment for stress, anxiety, depression, sleep, and other ones as well. Support services for the changes of lifestyle, tobacco, quitting aids, and healthy eating habits. For various types of teaching platforms, such as arthritis goal, diabetes goal, and how to handle the child's anxiety. And this has been used also more, and here some specialist nurses are actually acting as coaches in this system, and they can coach multiple patients at the same time and see if anyone needs extra support. And this service is can be reached by all digital devices connected to internet. There are also features called My Care Plan and there is a e-care plan that you can follow, and it's implemented mostly for breast and prostate cancers so far, but more diagnoses are implemented as we speak. Next slide, please. So here you can see some percentage, well, a short list of the usage of e-services, mostly the national wide ones. And so for the service own EHR on the internet and digital in 2019, well, it's been a raise since last year and until this year, September, by 68%. So, and this own test result service has been actually has been in place before, but now it has been well, so to speak, broadened, and now it's the change from last year. It's 532%, and support and treatment has the raise of 103%, and e-services total 98%. I see that I don't have so much time left, so I will speed up a little bit. So next slide, please. So in terms of digital care meetings, we have the healthcare services online, and it's been implemented. Firstly, it was implemented mainly, well, we can say that appointment with psychiatric and diabetes nurses and more, and joint care planning, of course. And we have both video care meetings and also in the telephone meetings, but mostly now it's video care through digital devices. Next one, please. So there were few private actors that started with this virtual meetings in 2018, 2019. But then today, each region has services or digital care meetings. They have to follow the private sector's success in this area. And Stockholm an increase with 1,100% in primary care since 2019 and 2020. So and 150% more providers are connected in the primary care. So the region of Västra Götaland, where I live, has increased the digital care meeting by 700% the last year. Next one, please. Then, of course, we have the self-monitoring. It's also been elevated and implemented at a high rate this last year. And of course, the telenurses had a profound challenge here, and also they have experience from how to use it. Next one, please. So what do healthcare consumers think about this very aggressive, well, very fast moving track here? So 5 out of 10 inhabitants are positive towards care, consultation, treatment through the aid of digital technologies, and 54% are positive towards the care of the home through support to digital technologies, and 7 out of 10 are positive towards digital solution for self-care. Next one, please. And in terms of the healthcare providers, what they think, I'm happy to say that. Sorry about the slide that is in Swedish, but on my left-hand side you have sjuksköterska, it means nurses, and they're actually the most positive group along the healthcare providers. Actually, 58% of them are very positive using digital technology in terms of healthcare. Next one, please. So we have paradigm shift here. I think the implementation of digital health technology has taken a huge leap, and it's good that the patients and the healthcare professionals are on board and like it. But I think also that we need to take a step back when we get the time and also see how these technologies have been implemented, and take some precautions and maybe do the things that we haven't had the time to do, as you think about during this very quick pace during the pandemic situation. So without further ado, thank you very much.
Thank you very much, Matthias. Once more, thank you, Sharon. It's already 1 minute over time. For those that have to go, thank you for attending this webinar. If you have 5 more minutes, I think it would be interesting to address a couple of questions that we have here. For example, for Matthias, there's a question from Pirkko, Kouri. How has Sweden supported nurses during pandemic time? And she's also commenting that in Finland, nurses are complaining too much work, not enough resources, and planning to leave their work, and are planning to leave their work. So yeah, what is your? I would add, what's also like, what is how they supported nurses during the pandemic? In addition, was it any additional training or support for the telenursing part?
There were not as many as we would hope for, actually. There was some central training for hygiene and so on and so forth, working toward, well, close to COVID-19 patients. But in terms of digital health, they were actually just given the device in their hands. I'm situated at university, so I struggle to get in these matters into the curriculum for the nursing education and the specialist nursing educations, and I think there is a lack of that there as well. So we have a huge work ahead of us to actually implement this in the curriculum of the nursing and specialist nursing education as well. So, but I think actually it was rolled out, and both physicians and nurses they didn't have that much. It was more just start using it and learn more as long as you keep using it.
I just have to. I think a question that Donna Floyd had for Sharon was also very interesting, because it brings up a blended system of telenursing with face-to-face nursing. Her question was, did you ever consider coordinating with the local home health agency to send a nurse to physically assess the patient before making travel to the Utah hospital facility? So collaboration with people, nurses, and living close to the or working close to the patients?
Yeah, that's a great question. I think one of the limiting factors for that is public insurance in the United States and accessing that for patients. So they have to have a reason to have the nurse go into. So we can't just dispatch a nurse to go out to someone's home unless we set them up with the service. If they are set up with the service, we definitely use the home health nurse to help assist with triaging patients.
What do you mean by setting up the service?
So I don't know how it works elsewhere, but in the United States, in order for the insurance to pay for home health to go out there, a patient has to meet certain criteria and needs to be set up by a physician previously. So if a patient's not set up with home health services, we don't have just like a home health group that we can call and dispatch to someone's home and say, can you go and assess this patient for us for fluid overload or whatnot. We utilize our ED and our urgent cares for that. And home health is a service we set up a patient from discharge from the hospital or a clinic if we see a need that a patient needs continued monitoring by a healthcare provider at home.
Thank you. We also have a question from Adolfo Sparenberg to Matthias. Congratulations for your nice presentation. My question is on the topic of COVID-19 vaccination. If you are currently receiving vaccines from just one pharmaceutical to cover the entire country, or eventually Sweden counts on different providers for vaccines. It's not very telenursing related, but I guess it's very, COVID-19 issues are in general very interesting.
Good question. I think so. The question is if we receive from multiple suppliers or just one supplier.
This is what I think.
Oh, yeah, we have multiple suppliers. I think 3 at least, and we constantly this national organization are seeking other suppliers, and but right now we are a little bit at halt. But we hope that they are trying, as I understand, to spread out the the mismatch in the logistics but right now it's actually on hold on several regions in Sweden. So but it's a good question. So I hope that we'll be able to spread it out on even more supplies in the future.
And from Dawn Hager, what telenursing training did nurses receive besides the platforms? And this might go to both of you. Sharon?
I think with us, what we did spend extra time triaging patients and being educated. So we did classes and courses to be able to better ask questions and to triage better than we would otherwise. So we did get some so that we would be able to be more effective.
Matthias, thank you, Sharon. Matthias?
Yeah, on this national 1177 platform that receives some education, but what I was talking about before was actually this virtual care visits that have been rolled out in a huge pace. So there I think we lack in terms of education.
Yes, I wanted to add that in many countries, including Sweden, if I understand, there was a phone center answering questions, no? And I don't know about the US. Yeah. Sorry, Matthias, yes?
Yeah, we have a phone. We have a 1177. This is actually the number that you call, and they also have, you can also log into the system and have a chat with a triage nurse, and then they have this self-estimation e-form that you have to pass before you get in front of the actual the triage nurse. So there's a center to it. So everything, it's because we had 21 regions that actually more or less perform all the healthcare in Sweden. We are not divided into so many organizations. So it's maybe it's a pros here for us because it's easy to have one solution for the whole population. In other countries, maybe it's harder.
But I wanted to say that it's very good to be addressed as a telehealth, telenursing or telehealth in a wider sense service, because in some cases it has been more as a, I don't know, help desk or customer support, and has not been, they didn't employ nurses or health personnel. So the answers that and the guidance the people were receiving from these phone lines was more like a joke, confusing the population, creating mistrust about this, and also giving wrong information in many cases. So even if the phone nowadays looks like an old technology and like a part of integrated part of the healthcare system, it's still a telehealth and telenursing platform that has to fulfill some requirements and is a way to deliver care and public health services nowadays. So I don't know what's your opinion about your comments.
Yeah, I
Sharon?
think the telephone has still huge potentials, and I don't think we should get rid of that means well, share information and keep in contact with the patient, because it's also very straightforward to use, and it's very hard to get malware and virus on it. So it's the downtime is not that often happening in the mobile in the system. But of course it happened there as well. But I hope that the telephone lines, that's possibility to talk to a person through a telephone line, it still will be open for quite some time.
And definitely not to outsource it to a marketing company or.
Yeah, and we should also bear in mind the demographic shift here and the elder people, the digital divide, and elder people, maybe, well, depends on their interest of course, but we should not roll out only advanced digital solution. We cannot exclude people that are not comfort in that digital environment.
Any final comments from you, Sharon, or from you, Matthias?
I just want to say thank you. And this is, I mean, unfortunate that we have this pandemic, but it's an exciting time too, because we're able to open up healthcare to patients in ways that we haven't been able to in the past. So I think it has opened opportunities for growth.
Thank you, Sharon. Matthias?
Yeah, second that, and I'm just sorry that I had to move on so quickly through my presentation, but well, maybe we meet up someday in the conference or so maybe we can talk more about that. So thank you very much for inviting me.
Thank you too. As both of you said, it's a challenging time, but this pandemic also unlocked potential. As I mentioned, the International Society for Telemedicine and Health has been promoting telehealth and e-health since 1993. But this pandemic gave a great growth in these services. It has important challenges, but also showed the opportunities, and it was the work that has been done until now in e-health was very useful now, and that platforms were ready, and nurses to some extent were ready to deliver care through this. So yes, and thank you for sharing your experiences. It has been very interesting and very useful. Thank you very much, and you joining us for this webinar. You will also be able to access the webinar on the website of the International Society for Telemedicine and Health in Education, and you can watch it after under the past seminars. Thank you very much. Bye.